Good morning. Welcome to the August 21st Public Health Nursing ITV. My name is Joy Hoskins. I'm the Director of Nursing here at the department, and want to welcome you and thank you for joining us today. We do have a couple of slight revisions to our agenda. TJ Sugg, who was originally going to present our Ebola presentation and the hepatitis B and hepatitis C guidance, is unable to join us this morning. So Dr. Craig Humbaugh, our state epidemiologist and deputy commissioner, will be providing the Ebola presentation this morning at 10:30. And then the hepatitis B and hepatitis C information, we'll provide that at a subsequent Public Health Nursing ITV for you all. Dr. Connie White is going to present an update on the community health workers following Dr. Humbaugh, so that'll be around 11:15 or 11:20. So if you have folks at your agency who might want to hear that information, hear about that information. Someone who just joined us has their mic open. Thank you. So that Dr. White's presentation on community health workers will be around 11:15. If you'd like to join us or have somebody else from your agency join us for that update. And then Jan Hatfield, a registered nurse consultant with the immunization program, will be providing guidance on this year's influenza initiative, including the guidance memo, and she'll probably talk about the VIS statements and the protocols and that type of thing. So she attended the CAVA meeting on Tuesday and provided the same information to the directors, and so she wanted to come and present the same information to the nurse leaders today. So thank you, Jan, for joining us as well. So with that, we'll go ahead and start with our first presentation. Sandy, if you want to come on up. Sandy Clark, RN, is the pediatric section supervisor as well as the school health consultant for the Division of Maternal and Child Health. And both Sandy and Becky Thompson, her tag team partner for this presentation, were both deeply involved with the rollout of the nursing delegation of insulin to unlicensed assisted personnel in the school setting. So Sandy is going to provide an overview of the regulatory piece that mandates and incorporated the new legislation regarding this delegation authority, new delegation authority for registered nurses. And then Becky is going to talk about the curriculum and some resources for school health nurses in this regard. So thank you to Sandy for coming this morning, and I'll go ahead and switch places with you.
Thank you, Joy. Good morning. We're going to go through, and I'm going to go through and tell you some of the highlights of the changes and things that have occurred first since this bill has been enacted, and then Becky's going to come up and talk more about the training manual that was developed by the Kentucky Board of Nursing. Now, House Bill 98 became effective July 15th, and it now allows for insulin to be delegated by an RN, an APRN, or an MD to unlicensed assisted personnel via syringe, pump, or pen in the school setting. It also requires that schools have at least one personnel available at all times for the entire school day to administer insulin, provide overview of diabetes, symptoms, and treatments of hypo and hyperglycemia. Glucagon administration was already exists in laws, but it's also included in this law. And also now students are allowed to manage their own care in the classroom, somewhere on campus, or at school-related activities. And it prohibits forcible transfer of students to a different school because of their diabetic needs. So that's a big change too. This affects not only the public schools, but it also affects private and parochial schools. House Bill 98 does. Now, like with many of our laws that are passed, there's always conflicts with other statutes and laws and regulations. KRS 156502 also had to be updated, and the Kentucky Board of Education, Department of Education updated this. Attached, Joy sent out the latest version that I sent her, 156502. And some things I just want to point out in that were changed for you. In 2C, they, instead of using the term unlicensed assistive personnel, somehow the Department of Education had a term called a non-licensed health technician. So that is virtually the same position. They just have a different term for that. And they added this to 156, and it says that this person has administration of health services in his or her contract as a specific job description or responsibility. So this is new that's been added. If you go down to number D2, they added that the responsibility of delegation has to be approved in writing by the delegating physician or delegating nurse, and that the school is going to be responsible for developing a form that this person, whether it's a person that's designated as a non-licensed health technician or it's someone else who has another job description in the school that will be providing this service, that they have to develop, and this individual will have to sign a consent form stating that they are responsible for this, that they feel competent, and they have had sufficient training for this. Okay, they cannot force an employee to take this responsibility on. The employee has to agree to this. The one point that's different from in 156, it's always been in this regulation compared to the new House Bill 98, is that 156 says when you delegate something in the school system, that person has to demonstrate competency. And so that's been a big issue for schools to understand, I think for all of us to understand and comprehend with these changes, because House Bill 98 doesn't require that, but 156 does. So that piece is very important, because one of the components of this bill states that you can use any program when you're delegating the administration of insulin, when you're teaching this, but it has to be within ADA's guidelines. And ADA guidelines and recommendations, or if you're familiar with their training programs, they have them on their website. You can have access to them, but they don't have a piece to demonstrate competency. So if you were to use ADA's format, you would be responsible for developing your own competency piece. So this is where the Board of Nursing came into play and was very helpful, because they did develop a training program for unlicensed assistive personnel, and it also has a competency piece to it. So that's very important. So remember that it can be found and downloaded on their website. If you go to www.kbn.ky.gov, and on the right-hand side, they have a column of new things that are going on, and they have that. You can go in, you can download the PowerPoint presentation and the manual, but it does have that competency piece. So remember, if you choose to use some other program, as long as it adheres to ADA's guidelines, you'll be fine, but you must develop a separate competency piece for that, for the delegating nurse is going to be responsible. Remember, it's not the nurses. You need to work with the school system. If you have a contract with the school, it is the school system's responsibility to develop this form for their employee to sign, even if you're doing the training and delegation. And remember that training is only good for the current school year. Okay, they have, just like we have our different rules, the Department of Education, their training cannot go into effect until July 1 of that year, and it's good through June 30th. So a lot of times schools will want to, when school's out, they have extra days, like from snow or weather, they'll try and want to go ahead and start trainings for the next year, but they're not valid until after July 1. So that's very important to remember when you're delegating. Okay, so that was all the changes in 156. And then the next KRS that was affected was 158.838, which is emergency administration of diabetes and seizure disorder medications. And this has been around for a while. This is the one that I referred to that already allowed for the delegation of glucagon. I think that was back, I can't remember when this bill was passed. It's been around for a while. So they had to go back and update it. So they added in 1A that beginning July 15, 2014, that it holds each local public school district of each private, public, and parochial school to have the one, this is where it comes into play also, one school employee at each school who has met the requirements of 156.502. for an entire school day to administer or assist with the self-administration of the following medication. Now, one big conflict that we have different is 156 only adheres to public schools. House Bill 98 affects public, private, and parochial schools. So I don't think any of our health departments contract with any schools other than public schools, so there's a little distinction there. So remember that House Bill goes in effect for all public, private, and parochial schools, but 156 only adheres. So for us, that means that competency piece, that is for public schools. If you have a contract with a private or parochial school, that competency piece is not affected. So that's a big conflict. So be sure. And if you have any questions afterwards, please send me emails and that type of thing. Questions, I'll be glad to help you work through it. It's a whole new process for everyone. This is going to be a big learning year, a big learning curve. Now, glucagon was already in the 158.838, but it did have to add number 2, where insulin can be administered subcutaneously. This is new. Another big change that they added when they first tried to pass, I don't know if y'all were aware of House Bill 98, they tried to include a seizure medication to put in there, but for Versed, but that's not approved yet by the Food and Drug Administration. So what they did in House Bill 98 and in 158, they added a sentence that says a seizure rescue medication approved by the United States Food and Drug Administration or any successor agency can administer. So they're thinking down the line that this is going to get approved and they're not trying to rewrite the bill. But at the time being, you cannot delegate for Versed. So that's and there's a big controversy over that. Remember about the competency piece. Now, remember that just affects public schools. It does not affect private or parochial schools if you have an arrangement with them. Remember about it's very important about the parental authorization form. Parents also, or the guardian of that student, must give their permission, have a written statement signed acknowledging that the school will not incur liability if an unlicensed person administers insulin to their child during the school setting or the school day. So this is another form that the school is responsible for developing. We are not responsible for it, but the Department of Education, the individual school system is responsible for developing this. And then there again, the training is only good for 1 year from July 1st through the 30th. It's very important if any of our nurses are involved in emergency action plans, or if you sit in 504s or IHP, make sure that this information is stated in that specifically, what is written. Of course, the school district will have the lead in this, but your input would be valuable if you're a part of these meetings, so make sure that this is included. Let's see. And then the one other big change was that they cannot force a student to go to another school. Now, just because of their diabetic needs. Now, this doesn't mean that if they have multiple chronic conditions that they may determine it might be better for that student to be sent to a specific school where there's maybe a nurse on board already or some other kind of health care, a school health-based center that's in place. That doesn't mean they can't. That's still the school's discretion. But just because they're a diabetic student, they can no longer mandate that this student be sent to a specific school just because they're diabetic. Let's see what else. I think that was all the changes on that. And then the other big thing as a result of this is the Kentucky Board of Nursing updated their AOS, Advisory Position Statement number 15. They no longer have number 30, which was an advisory statement opinion that related to schools and delegation in school nursing. So they have removed that. But they've updated AOS number 15, so it's very important that you all want to read through this, that you want to save it or download. I always like hard copies to go back to refer to. But what they did is they extended this to include the licensed practical nurse. Because remember, this is another big thing when 156 came about, is that LPNs are allowed to delegate in other health facilities, nursing homes, hospitals, that type of setting, but they cannot delegate in the school setting. Nurses can can do the same functions. Their scope of practice doesn't change in the school setting, but they're not allowed to delegate. So you can't use an LPN to train unlicensed people in the school setting. So that's a big thing. So they had to add that in their update in the advisory opinion since they took out 15. They emphasized in this, remember, when you're delegating, that nurse delegating is also responsible for periodic observation and evaluation and follow-up. Now, the Board of Nursing does not regulate or tell us how often we have to do that. That's at the nurse's discretion, but that is your responsibility. If you delegate any procedure, not just insulin, no matter whether it's catheterization or anything else that we're able to delegate within our scope of practice, you're responsible for developing some type of time frame on periodic observation evaluation. And you may want to determine that depending on the people that you're delegating to. Some you may feel might need more observation and periodic follow-up than others. So that is something that is still the nurse's responsibility. Let me see. They added, for you all who do, they added KAR 201-2040 that talks about and governs delegation of nursing tasks. They put that with this advisory opinion. It's really a nice booklet. They also have the scope of practice determination guidelines and decision tree guidelines. And I will tell you, if you're the nurse delegating, you really, it's really important because remember, it's your responsibility. So you really need to know how and know your scope of practice. You need to know this. You need to refer back to this. And yes, I know when you're in the setting, you may go in the principal, the school building principal, the superintendent may say, these are our people, we want you to train and delegate. But it is still the nurse's responsibility. If you feel like that person is not able to do this and they're not performing and cannot demonstrate competency, it is the nurse's responsibility to say, this person I don't feel is safe to go out there and provide this care. So remember, it's still the individual nurse doing the training who has the last decision whether this person is competent or not. So you have to use your judgment. So that's why it's so very, very important. I've always stressed knowledge and needing to know this. Becky's going to come up and talk about the manual and the development, and then at the end, we're going to open it up to questions, and then if you all don't have any questions, I've got a few that came up when we did the training. KSNA had an orientation, KBN was there, and this manual, all these changes were presented. So I took some notes, and some of the questions that were asked there, if you all don't have any, I'll go through, and it might sort of open up, and you might give you something to think about, and we'll go over that. But Becky's going to come and talk about the manual and the development of that. Thank you.
Alrighty, good morning. As Sandy said, I was very involved with the development of this manual that is the insulin administration by unlicensed personnel in the school. When Board of Nursing contacted my division, I work with the Kentucky Diabetes Prevention and Control Program. Our goal was to get some expertise in helping to develop this manual. So there were several other writers with the creation of this manual. Pam Hagan from the Board of Nursing was our lead person on this. I myself am an RN and a certified diabetes educator. Stephanie Jensen is a RN certified diabetes educator that works with HOSER's Pediatric Endocrinology Department, so she is very much working with the kids. And Michelle Coble, who is a registered dietitian, certified diabetes educator, worked on the team, and Michelle works out of the Lincoln Trail District Health Department, but she has also been the one responsible for overseeing diabetes camp for our kids for a long time. So what we try to do is to pull together expertise. Also, Sharon Glass was with our program who represented the school side of it. So there was a lot of learning that went on even amongst ourselves as we were developing the manual. One of the things that I would suggest that you do is that you go online and print out the complete manual. The manual actually has several sections to it. The first part is the manual that is for you all as the school nurses. There's a lot of information that you can use. And then the second part of this has the PowerPoints with it. And with each of the PowerPoints, what we tried to do to make this a little bit easier and less stressful for you all, if you print your PowerPoints out with the slide and the notes, the content that you need to make sure that you teach and reinforce to your unlicensed personnel are listed below. And if you have this in a printout format like what I have, if for some reason, if your IT technology is not working or it's not conducive to lug a laptop around, you can sit down right with the book and you can go through the information. Another item that is in this notebook, there is already a certificate of completion that has been designed by the Board of Nursing, so that makes it a little bit easier for you all, because I do realize you all are extremely busy. Sandy had mentioned that one of the components is that you have to demonstrate competency in all of these different areas with your unlicensed personnel. So here again, what we tried to do in your manual, there will be a competency test, a written test, and not only did we give you the test, we gave you the answers. So it was to ease that stress of, oh my gosh, what if I don't know the answers to these questions? And I have to tell you all, in working with Sharon Petglass, in this, you know, hats off to you all as school nurses, because you do deal with an awful lot of information and keeping up with a lot of things. And so we tried to make this manual as user-friendly as possible for you.
Someone has their mic open. Would y'all mind to check your mics, please? We can hear you talking. Thank you. I'm sorry.
With the competency test here, there are a total of 43 questions. There are multiple choice. I think there's a few true false. But we also made sure that the information, this is basic information, signs of a high blood sugar, a low blood sugar. There's a couple of activities in here where we ask the unlicensed personnel to count carbs if that's what's delegated to them. And we made it so they can't just simply go through and guess the answer. You know, if you're administering this test and working with someone, I encourage you to have that person show the math. It makes it easier because you may see where they're going wrong, and it's important. And one of the things, there is not a test in here for pumps. If you have a child or a student that is on a pump, you will need to develop that part of the competency. You can look at some of the questions, and because pumps are so varied, know that with pumps, even as a school nurse, if you do not feel comfortable, you can always Google those websites. We can always get you in contact with a pump representative. I was recently at a national conference, and there's like 3 new pumps that are coming on the market. It is changing very, very rapidly. One of the things that I had submitted to Joy, I did try to go through and find different links for you. I know it's one thing to say that there are websites out there, but we can all get lost in websites. So what I try to do is go through with these websites and get the most direct link for you. The first one on here is the link to the Board of Nursing. The second link on here is to my program, which is the Kentucky Diabetes Prevention and Control Program, and there are multiple tools for diabetes, not just necessarily for children, but you might find usable. There are PDFs on there where you can print things off. The third link, Diabetes Health, will take you to a magazine that always has a lot of online charts. And the nice thing with the charts is all the charts, especially for the meters, have the 800 numbers with them. So if you're dealing with a student and a meter you're not familiar with, or you need some assistance, you can always call those 800 numbers. The 2 big insulin companies, which are Novo Nordisk and Eli Lilly, their websites are on here. You are going to see a lot of insulin pen administration. And what we know is that not everybody, including parents and including nurses, do the insulin administration with the pens correctly. It is very important that you prime these pens. And yes, that means wasting a little bit of insulin. It's 2 units. But if you don't prime your pens, then that's 2 units of insulin your student does not get. So I encourage you to review for your own content how to do these pens. They're like a 5 or 10 minute video clip, and you can also use these with teaching your unlicensed personnel. And then the last link on here is to the National Diabetes Education Program. You can download the free manual, which is helping the students with diabetes succeed. And you can also download everything from the NDEP. It's free. If your school decides they want to put their logo on there, the information from this particular website, there are no copyright concerns other than they ask that you keep their logo NDEP on there. if you want to put your school name or your school logo on there. So there's just lots of really good information. So I'm not going to go through the individual manual, but there are lots of different components to it. We do incorporate some of the ADA's video clips in there. So like I said, just go through, print the manual out, refresh yourself on some of this content before trying teaching it to your unlicensed personnel, if that's what your school has decided that needs to be done. And then if you yourself do not feel confident with doing the diabetes part, be sure to get in touch with Sandy and we can see what we can do to get you some additional assistance. So we'll open this up to questions.
Let me remind you, even if the school has a school nurse or they decide they don't want to delegate, they are still responsible for training, having one person in the school building at all times who knows the signs and symptoms and how to treat hypo and hyperglycemia and to administer the glucagon. So they're still responsible, even if the nurse is not going to delegate the administration of insulin to unlicensed people. They're still responsible for that. Before I come up with some scenarios, and we'll go through some questions that came up at the conference, does anyone out there have any questions for either Becky or myself? No questions?
When does this take effect?
This went into effect July the 15th. So it's been in effect of this year. Yeah, this year, okay. Last month. Yes, ma'am.
Okay, thank you.
You're welcome. Any other questions?
We have a question.
Yes.
If the nurses will be covering the insulin treatments, or the lunchtime treatments, snack treatments, breakfast treatments, but we're not in the school all the time, do we have to have someone in the building at all time that is trained on the insulin or just on the highs and lows and glucagon?
There still has to be someone in the building. If you're only going there to administer the insulin, there would still need to be somebody trained in the building for backup.
Okay. My other question is, if the doctor's orders say they're independent, do we still need to have someone trained?
Yes, I would advise you to do that because that student may become whatever and incompetent, not able to administer their own insulin. They may have an emergency. So, yes, you would still need someone trained for backup.
All right, thank you.
You're welcome. Other questions? Okay, well, let me just go through some, and you all just stop. If you all think this generates any other questions, please stop and feel free to interrupt me. One of the questions that came up said at the conference was, is the local health department nurse considered the one person by law to be trained in the school? That could be yes, but you would still need a backup person to be trained, and especially you still have that consideration, what if that student goes on a field trip? And this has always been a big issue with our diabetic students. The other one, another question that came up was, what about delegating Versed in the school setting? Remember, this is where I said that KRS 158.838 changed their language to say it has to be, the medication has to be FDA approved for seizures. And Versed is still not FDA approved. So until that changes, if that ever changes, then yes, you'd be able to delegate Versed. Even though I know that Versed is still delegated in some areas, it is not recommended. And this is a question just alluded that you asked me, if you have an independent diabetic high or middle school student, do you still need someone trained? And we would say yes, because they might become incoherent, not be able to do their own. And also another thing that's going to be hard, all the school districts, because of CARA, have local control. So local school districts need to be developing their own policies referring to this, besides what have been changed in regulation. And another question was, can you document emergency medications into Infinite Campus? Yes, and that includes inhalers if it's given as an emergency medication and not daily. If the school site has an on-site daycare center, does someone need to be trained? And there again, the answer would be you need to check with the school board and the local policy. It depends on whether that daycare center is associated through the school district or whether it's an independent agency that just has their site on the school campus. And then does 158.838 cover private and Catholic schools? There again, yes, to clarify, this change affects public, private, parochial, but remember 156 only affects public schools. Okay, so that's where that competency piece plays in. If an LPN is assigned to a building or school, and an RN does the training and delegating, can the LPN be called for assistance, or does the RN have to be called? It's perfectly fine in the school setting for the LPN to confirm the carb counting and to administer the insulin themselves, but any question needs to go to that nurse who did the delegation. And remember that the nurse delegating does not have to be in the school building. They have to be accessible by phone, though. Okay, so because a lot of nurses will go to different campuses and that type of thing. What do you do if a parent refuses to allow the unlicensed assisted personnel to administer care and requests an RN at school? There again, you can be a part of this, but this is up to the school district, their policies, their board attorney. And one thing the RN can do, if you have time to sit in with that parent, you can show them the training module, show them how you do the competency, and sort of help invite them to any training to observe, to help build the confidence in that. But this is really would be a issue that the school would need to handle, and not the individual nurse. How long, another question that came up was, how long do these records have to be kept related to the training? This past year, KDE updated it, and you can find this in their Health Service Reference Guide on the website. These records would now need to be kept up to 6 years after that child or student leaves that school. So 6 years after. So if they're in elementary school and they stay there through their high school years, their senior year, then it would be through that plus 6 years after that. If they happen to move, transfer out, it would be 6 years after they left the school district. Let's see. Oh, here's another question that came up. If the local health department was asked to come and train the unlicensed personnel, but they are not providing school nursing services, how do you handle this? Remember, it says an RN, an APRN, or MD may provide the training and delegate. But if the delegation occurs, the RN is still responsible for the periodic follow-up and observation and evaluation to this. But this needs to be specifically stated in your contract between the local health department and the school district. So I know when I did the contract training, which was back in April, I sort of alluded because we thought the bill might pass that you needed to be specific, because some of the contracts I have seen, some of the local health departments are not allowing their school nurses to delegate and train. So this just needs to be specified in the contracts. Can an RN or APR be a trainer only? And this came up. Say the school just wants you to come and do the training but not delegate. And that's perfectly okay. One of the examples that came up was given this. If you would think about when you were in nursing school, you had your professor who taught you medication administration and you did checkoffs. But yet when you go out and you practice, they're not responsible if you make a mistake later on. So this would be the same scenario. If you're just strictly providing the training, that's fine. But if you're delegating to these individuals, then yes, you are. So you've got to be clear, and there again, you would need to specify in your contract if you're just providing the training or if you're actually going to be doing the delegating, the oversight.
So local health department saying it could potentially have a contract solely for the training.
Yes, if they wanted a separate and just wanted to come in and provide the training,
okay,
but no delegation and oversight of it. But yes, so you'd have to do specific. So those were some of the main questions that came up at our session. I think we really expected more questions to come up, but I think this is so new and it's such a major change. I think that everyone was so sort of overwhelmed. So we have only really some schools have already started, some are getting ready to begin. We have slowly, Karen Irwin, the consultant at KDE, we're both receiving a few emails, but really not a lot yet. But please don't anytime. Please email me or pick up the phone and call if you have questions, because this is going to be a big learning year for us. Did anybody else think of any other questions?
And I'd like to add something with the training. When we created this training, we estimated this training would take a minimum of 4 hours. This is a lot of content to teach someone. And so as you're trying to plan out your education or your time that it takes, I would say the first few times or the first time you bank on at least 4 hours, depending on the learning needs of your unlicensed personnel. And it's all about the support. If you rush through it to train that unlicensed personnel, you're probably going to get a lot of questions back from them. You may have to do a lot of retraining. And while I know everybody is pushed for time and has a lot of time constraints, I think we have to keep in mind the person that we're ultimately trying to assist, and that is the student with diabetes.
I have 2 more questions.
Okay.
Thank you. What if a school health nurse or a nurse leader who was going to be working with a school, what if they missed the training in July? Are there going to be other opportunities for having that discussion?
Joy just asked if there would be other trainings for anyone who happened to miss the conference, and the answer to that is no. One of the things being, this is actually the training manual was developed by the Board of Nursing, so really they're the ones that does the oversight, and they felt like nurses have already had the basic training as far as insulin and diabetes. You might just need update, and that's what this manual's for. The other thing is it's still up to the nurse. If you're going to take on this responsibility, you need to make sure you always stay, no matter what, whether it's diabetes, medication, whatever you're doing in your practice, that you're staying up to date on the latest techniques and changes. So they felt like this manual is just developed for you to teach the unlicensed person. And one of the other things that will help is you remember the medication training that was developed between Kentucky Department of Education and DPH. We went through that and we did all that training. That's a requirement. So the nurses should already have that basic of how to train the trainer. So this information is just a matter of the nurse going through it, putting together, and doing her own development. Okay, thanks.
And then I have a second question. Okay. Would you be able to have the FAQs available on one of your all's websites, so we'd be able to reference those and share those with the nurse leaders?
That one. Yes, we can work on that. I'll work on that.
That would be great. And I can either send that out with the minutes, or we can post it on the nursing office website or your all's website, however you all want to do it.
Okay, we'll follow up with that.
I think that would be helpful.
Okay.
I know all the other trainings for unlicensed personnel is on the website. Is this insulin delegation on the website too, to be for the teachers to review?
It wasn't taped. No, this was not taped. This training was not taped. The only thing that's it's different from the other. The only thing, you can go to the Board of Nursing's website and download the manual and the PowerPoint. Because
I know.
I'm sorry. Go ahead. I didn't mean to interrupt.
I know the unlicensed personnel training for the inhalers and the glucagon and PL meds and stuff like that are on a website, and they watch that website or do the manuals on that training on that website, and then they do the test, and then the nurse watches them check off. So I was just wondering if this was going to be on the computer too.
No, this is not set up to that. That's not saying you wouldn't have that option if you wanted to develop that and do that yourself, but this is not how this training was developed.
Okay, thank you.
You're welcome.
I know you.
Go ahead, Nancy.
Sorry. I know you mentioned that the records will be kept for 6 years after the child leaves the school. Do you happen to know if this is all medical records or if this is just the insulin record?
Well, this is the KDE's requirement, the Kentucky Department of Education. Since
Or
it's
just this?
no, for all their medical records. For all their records.
Okay, that's perfect. Thank you.
You're welcome. Any other questions?
This presentation, as a part of today's Public Health Nursing ITV, will be archived, and so that might be an option for those of y'all who are participating today and want to share the information and the discussion about the regulations and the curriculum and the FAQs. That this portion, will be available at probably in a couple of weeks or so. If you want to share that with either your staff at your local health department, your school health nurse staff, or your with your schools partners. Okay.
Anything else? Okay, thank you all. Remember, please call or email with questions and things, because this is a big change. We're all learning. Thank you.
Thank you, Becky and Sandy, and they've worked diligently on this new legislation, and they represented DPH very well. And if you have any questions, I feel certain that between the two of them, I'll be able to help you out and provide you the guidance that you need or refer you to the proper folks. So thank you again for all your hard work. Okay, Dr. Humbaugh is, we're running a little bit ahead of schedule, so I'm sure he'll be up here in a few minutes. What I'd like to do is go ahead and ask Jan Hatfield, nurse consultant with the immunization program, and she's the influenza coordinator. She's going to go ahead, and we understand, I think I've heard that some local health departments already have their vaccine. Is that correct? Okay. So what she's going to do is go over the memo and the information that you all need for the VIS statements and the administrative part for you all, so you all can go ahead and start your flu clinics. Okay? The protocols, I don't want to leave those out, so thank you, Jan.
Good morning, everybody. I just wanted to give you all a brief update on what's going on with this flu season this year. Thankfully, we had a fairly mild to moderate flu season last year. We hope that it's going to be the same this year. There were no major changes to the flu vaccine this year. It's virtually the same as it was last year. We're going to have quadrivalent, hopefully a bigger supply this year of that than we had last year. But routine annual influenza vaccination recommendations are still the same. All persons 6 months and older. CDC has not changed that. The only recommendations that were added this year to the protocols were it's just a recommendation for the use of a nasal spray vaccine, and it's the LAIV, the live attenuated influenza vaccine in healthy children 2 to 8 years of age when the nasal spray flu vaccine is immediately available, and if the child has no contraindications or precautions to that vaccine. However, if the nasal spray vaccine is not immediately available, children in this age group should go ahead and get the regular flu shot that's designated for their age group. Vaccinations should not be delayed just because you don't have the nasal flu. Coding and billing, Cynthia will be here later to talk a little bit more about that, but we're not going to schedule an ITV this year because of basically there were no significant changes. Everything's pretty much the same. The flu memo is in process and it will be out in about a week. Hopefully, we've got the protocols under review right now, and they will hopefully accompany the memo. Be sure to get them updated and signed for this year's flu season. The training for last year's flu season is still on the LHO website, the Local Health Department Operations website, and you can view it if you have any, want to just a review. Override procedures as far as billing, again, has not changed. Send that to Janet Overstreet or the local health department's help desk, and they can take care of that for you. And I guess that's it. Does anybody have any questions? Well, feel free to let us know if you have any questions anytime.
Jan, do you know if they've set the Medicaid rate for flu yet?
That would be a question for Cynthia. I don't have any idea.
Yeah, I don't know.
Yeah, I don't know. I'm sorry. Cynthia will be here a little bit later to answer that, hopefully.
Glenda, will you make a note to ask Cynthia that when she comes?
Okay.
All right, thanks.
Oh, the VISs they have been updated as of August the 15th, so they are out there. We will be sending them as well, along with the memo for you to have.
Thank you, Jan. And so just to kind of wrap it up, the emergency protocols are in process.
Yes.
And then there will be the memo with the guidance,
Yes.
the VIS statements, and the vaccine administration records. Will those be included as well?
This will be included as well.
So our goal is to have everything all it might be in 2 different emails, but we want to coordinate the release of this information among immunizations and AFM and local health operations and the nursing office, so everybody will have that information on the same day, and, you won't have one part of the information and then the second part of the information, 3 days later or whatever.
Right.
So our goal is to have it all released as soon as possible,
Right.
Hopefully next week is
Yes,
our goal,
is
right,
our goal,
Jan?
yes. It'll go to the local health department directors and all lead nurses.
Okay. Any other questions for Jan? All right. Thank you so much, Jan. Cynthia, we did have a question. Has the Medicaid rate been established or identified for the influenza vaccine? We'll put you on the spot.
No, it's okay.
Okay. Okay.
I was going to tell you that basically the rate has, right
You
now,
want
it's
I'll
still,
switch places with you.
no, you're fine.
Okay.
Right now, the rate is still $18.40, but we're trying to talk to them and get the MCOs to pay more because for the adult vaccines, we don't think it's nearly enough. So that's why we're still talking with them. I don't know if the contracts have been signed yet. I can talk to Sharon Trivet to make sure to find out if that's really the case or what's going on with that. But and once we find that out, we'll send out a mass email, of course, so that we can make sure that everybody understands. But right now, it's still $18.40 for Medicaid.
So that way, I just asked it just a minute ago. So $18.40 until we hear otherwise, and you all are negotiating with the MCOs specifically for the adult vaccine, or all of it.
Well, we really want to change how they pay vaccines.
Okay.
Because right now they pay on the actual vaccine,
Mm-hmm.
and we think they should pay on the way that normal people do, which is the administration of the vaccine along with the vaccine.
Right.
But that's, like I said, that's in the real world. We're in our own world. So, but right now we're trying to change the way that they do that. So hopefully we can get that changed around. So.
Sarah, is Dr. Humboldt on his way, or should we go ahead and have Cynthia present?
I'll go ahead and have Cynthia. He
Oh.
will be here as soon as
Okay, all right. Thank you for checking for me. Thanks you all for your flexibility today. And I know that several of you all arrange your schedules to be here for just certain parts of the agenda. But sometimes things happen and life happens, and so we're going to adjust and do the best we can. And so again, I thank you for your flexibility. What I'll do is go ahead and invite Cynthia Robinson to come up and review the coding for local health department clinic and school sites. This is a review of the presentation that Cynthia provided on August 7th. And so we wanted to afford the local health nurse leaders, local health department nurse leaders, the same opportunity if you didn't get to join Cynthia on the 7th to review the information. And she's going to talk about any frequently asked questions she may have received and give you all an opportunity to review and discuss this information as well. So Cynthia, let me see if I can get your presentation pulled up here.
I have it if you
How long do you think you'll be?
How long?
Mm-hmm.
Depends on how many questions you ask me, because I don't really have a whole lot to present. I mean,
Okay.
unless you want me to go through the whole thing again.
Yeah, I think you're okay.
But. You want me to. Because it's a lot of information you've heard, I don't know how many times.
All right. Thank you, Cynthia. I forgot to say that you were from Local Health Operations Branch. You're an internal policy analyst 3, and so thank you so much. She's our billing and coding expert. So thank you again.
More coding, not billing.
Okay.
Okay, well, I did have a few questions. Actually, we can thank Brenda from Laurel County for this question about schools, and it was basically about the pulse oximetry code, which I do have a code. However, this code is 94760, and it was asked if they could actually bill off for the pulse oxygen, I can't say that word, so just know, you all know what I mean. So, so the pulse ox, this is something that is normally not billed when you do an office visit. And when you're in the schools, it's going to deny for basically the CCI edits. It's the correct coding initiative is what that is. And if you bill that code with an office visit, any insurance is probably going to take the lesser of the two. So it would probably not behoove you to bill this code. So in my opinion, I think you just need to stick with your office visit. I do have the code if you want it, so I'm going to email this to Brenda, but if it's 94760, but again, like I said, according to the that NCCI edits, it's not a good thing to do with your actual billing of your office visit. So, because they're going to pick one of the two, usually is what's going to happen there. So, if there's any other questions about the 25 modifier, because I had a few questions about that, but I think it was mainly to do with my examples that I gave, which I don't believe anybody really has that big of an issue with it, but just in case. I can't remember. How do I do that? Is it the 3?
3.
That's what I was thinking. Okay.
There you go.
Okay. That's a little fuzzy, but I hope it's okay out there. All right, so I figured I'd just go through here and show you all my examples just because I wanted you to know about, just to make sure that everybody's really, because that was the main questions that I had when I did this back on August the 7th. And I had a few questions based on school, which, let me go over that just so you all know. As far as the daily medications, that's something that we are not allowed to bill for, according to EPH policy. So daily medications are not a billable service anymore. So just so everybody knows, that according to our coordinated school criteria, the coding criteria for the coordinated school health, it's not something that we can bill for anymore. So just know that that's what is going on with that. And then I have 2 examples here of the basically what you can bill for in the schools. Just remember that for the brief, it's the main thing you need to keep in mind is it's minimal to low severity. Very small, brief visits, that type of thing is what you're going to look at. And then you also have the limited that you can bill for in the schools. And those are the more complex, those are more in depth, that type of thing, that actually you're treating several different minor issues going on with that patient or that child. So just remember that when you're actually billing for schools. The main thing I also wanted to go over too is the 25 modifier. Just remember when you're actually doing these visits, which I'm showing you the example of the 39-year-old established patient that comes in for family planning preventive visit. And then the APRN actually finds vaginal warts with the permission of the patient, treats. I'm giving you the coding for both of these things that you're going to do, which is the 99395, which is your preventive code. And then because she's treating an additional issue that is actually separate from the preventive, you can actually code an additional E&M visit, which is that 9921325. Okay, so that's just something to think about. Now, I get a lot of questions about this one right here. This is the one that I had a few questions about, which is the 17-year-old established patient comes in for family planning supplies, and the RN finds out she has not received her Gardasil vaccine. And she also counsels per component, and then she actually codes a W9212, which is a limited, with the 25 on it. And then she also codes for the administration, which is the 9460, and then 90649. And that's the vaccine, of course. The reason why she's putting that 25 on that office visit is so that she actually gets paid for everything that she's billing. If you don't have that 25 on there, usually Medicaid or insurance will not pay that because they think that you're billing an office visit with a vaccine. And they don't see the reasoning behind the fact that it's something that requires, you're not just doing the office visit for the vaccine, you're actually seeing them for family planning. So if you put the family planning, that office visit with the 25 modifier on it, along with the diagnosis that goes with that family planning, then you should be fine, along with your administration of your vaccine. Okay, so just something to think about. That's how you have to do that if you want to get paid for it. So, but that's basically what I wanted to go over with you all. Is there any other questions or anything that I could go over while I'm out here?
Cynthia?
Yeah.
So the nurses can code a modifier 25, that's not just if the practitioner sees them and then the nurse sees them. If a nurse is doing that supply visit and the nurse gives the administration, then we code a 25 modifier?
Yeah, if you're doing the supply visit, you as the nurse, and you're saying that the APRN actually has not seen the patient on this date of service?
Correct.
Okay. Then, yeah, you can actually code this the way that I've shown here in this example, showing the 25 modifier along with the administration.
Someone has their mic open. Would you mind to check your mic so we can hear conversations in the background?
Please check your microphones and make sure they're on mute.
That's all.
Clark County, did you hear my answer?
I did, thank you.
All right, hopefully it made sense. Anybody else? Any other questions?
Is your presentation posted yet on the local health operations website, Cynthia?
I'm not sure if it's actually there, but it is on track. Did I do one or two? Do you know? As far as
2.
Thank you. I can't remember. Okay, so if there's no other questions.
This is Rebecca in Harlan County. Does the 25 modifier also apply in the school setting if I see a child for a problem visit and a vaccine on the same day?
No, ma'am, because I went over this on the August the 7th just to let you all know that in the school settings, we only have room for one visit. That's it. You're only going to get paid for one visit in the school settings, and that's it. So it's not a good idea to use that 25 modifier. Any other questions? Okay, last and final call.
Thank you,
All right,
Cynthia.
thank you.
Sorry. Thanks again, Cynthia. Next, I'll go ahead and introduce Dr. Craig Humbaugh. As I mentioned, if you all weren't with us at the beginning of the ITV, I mentioned to you that TJ Sugg was unable to join us today, but Dr. Craig Humbaugh, who is our Senior Deputy Commissioner and our State Epidemiologist and our Division Director of Epidemiology and Health Planning, and he was so gracious to come and present today's PowerPoint presentation and training on Ebola. And certainly this is a topic that's in the news, and even this morning in the news they had an update on the 2 patients who were in Atlanta in the hospital. So thank you, Dr. Humbaugh, for coming, and I know you have a very busy schedule, but I know we're very interested in this topic, and so thank you so much. And I'll pull up your PowerPoint for here for
Great.
you.
Well, thank you, Joy.
Uh-huh.
Appreciate the opportunity to pinch hit for TJ this morning, and this is a timely topic. I'll try to do my best. I did not create the slides, so hopefully this will go fairly smoothly. And then when we have time at the end for some questions and answers,
Absolutely.
Joy? Okay,
Absolutely.
great.
Okay.
Okay.
And you're not TJ, so.
No, okay. So do I just use this to advance,
use
or
use
can
your
I
mouse
use it now?
Yeah,
Okay.
Yeah. Okay.
Great.
You want me to do it for you?
No, I think I'm fine.
Okay.
Yeah. How do I go backwards, though, if I want to?
You have to just
Okay, you have to do
yes.
it manually with a left click.
Yeah.
Okay, all right. Okay, well, let's talk about Ebola virus. This is, as Joy said, a hot topic. It's one that we all need to be a little bit more educated about so we can be aware of patients who might meet the risk factors for this particular disease and know what to do in terms of workup and potential proper isolation. So TJ had several objectives for this talk, and they are to talk about the history and epidemiology of the virus, talk about the structure, classification, and life cycle. He wanted to talk very specifically about the microbiology. I will not be going into that as much as he would be because he's very interested in that. I will talk about the disease, symptoms, and progression of the disease in its natural state, discuss how we diagnose Ebola and how you would collect a specimen for that, treatment for Ebola virus, and then describe infection control and prevention guidelines. So a lot of the slides we've abbreviated Ebola virus disease as EBD, okay? And that's consistent with what CDC is doing, but that's the same as Ebola virus disease. So let's start with kind of the history. This was a virus that was first recognized in the 1970s in sub-Saharan Africa. We've had several outbreaks that have happened mostly in Africa since then. It's really a whole family of RNA virus diseases, but the most well-recognized one is called Ebola virus. It's named after a river in Zaire, I believe, which is now called the Democratic Republic of the Congo. Unfortunately, it has a high fatality rate, and the fatality rate with the current outbreak is somewhere around 60 to 70%, we believe, and we're trying to get better numbers on that. As I said, this happens periodically, but this 2014 outbreak, which is occurring in the countries of Guinea, Sierra Leone, Liberia, and now Nigeria, is the largest outbreak that we've known worldwide to date since this particular virus was discovered. The transmission occurs through direct contact with somebody who's infected. So it would be contact with blood and body fluids, and that can happen either while the patient is still living or after the patient has died. Thank you. I think you all know what an incubation period is, but it's the time from when a person is exposed to his disease to the time when the person begins to show symptoms. And in this case, it can range anywhere from 2 to 21 days. But more commonly, people start showing symptoms anywhere from 4 to 6 to 10 days. And the symptoms, and we'll talk about those, are usually pretty nonspecific to start with. It may just be fever and gastrointestinal distress. It's felt that the patients really can't transmit or be contagious until they develop a fever. But as I said before, they could still be contagious in a post-mortem state, and you'll see that that is one of the risk factors, is having participated in funeral rites or kissed people who are no longer living, who may have died of this disease. and that it may be a cultural practice that's continuing to propagate this particular outbreak. We think science would point to the current scientific evidence that the natural reservoir for this particular virus is fruit bats, which are endemic in that area of the world, but it hasn't actually been pinned down. Often these outbreaks are traceable to specific epizootics in which is basically an epidemic within the animal population. So here is a slide that TJ put in here about the natural distribution of Ebola virus in humans and animals. And you can see that from the red countries are areas where Ebola has been identified, and this is mainly in sub-Saharan Africa, or all in sub-Saharan Africa pretty much. Although there have been scattered other places that you can see where they've had they've had other cases, and these might be cases that were actually in travelers that came from endemic areas. So this is a slide talking about basically the fact that bats can be reservoirs potentially of this disease. We don't know this to be sure, but we think that fruit bats are. They can cause epidemics, which are called epizootics, in the animal population, or they can cause epidemics within the human population. So there's a whole cycle that probably occurs here among non-human primates and this small antelope that I think is called a duiker. I think that's the proper pronunciation, and then you can see that in the upper left hand or upper right hand part of this slide. So I think the word epizootic is interesting because when I came to, this is a sidebar, when I came to Louisville and I first started public health in Kentucky, people would tell me, oh, well, what's wrong with you? They'd say, oh, I have the epizootic. But, you know, in the correct use of that term, and Dr. Poe is sitting here in the audience today, so he can correct me if I'm wrong, but the correct use of that term is really not among humans. Right, Dr. Poe? Okay, it's among animals. But it's just interesting that people will say that, oh, well, I have the epizootic, which I think just means I've got some type of virus. The crud. All right, so this is just giving you an idea of the numbers and types of cases that have, this is from last week's data, that have appeared in West Africa. And you can see that we're talking about a couple thousand cases and unfortunately over 1,000 deaths. And again, that would translate to somewhere around 60%, 70% mortality, which is in this day and age a very high mortality rate. So essentially more people that get this disease die than survive. And so therefore, you know, there's a lot of fear about the disease. It's very serious. We're taking it very seriously. And so is the world. So one of the things that we can do is to help people. If we can help control the outbreak where it's happening now, then it's less likely that that outbreak somebody will come to the United States with the disease. But if the outbreak continues, then I think or escalates, it's anticipated that that it's likely that at some point somebody will come here and likely have the disease who's been a traveler to that part of the world. And you can see here, these are areas that have specifically been affected in Liberia, Sierra Leone, and Guinea. So many of you know Doug Thurlman. He's our Deputy State Epidemiologist. He's also our CDC assignee to Kentucky. He's been here about 12 years, and he's a PhD trained epidemiologist. But you may not know, but in his life before being an epidemiologist, he was a Peace Corps volunteer to Liberia. So he is actually now serving as part of the away team that CDC has on the ground in Monrovia, and he is helping us prevent the spread of this disease to the United States, hopefully. He has already been charged with setting up an emergency operations center by the CDC in Liberia, and he's used some of Kentucky's plans to do that here as a way for him to understand how to set up a similar system in Monrovia. So yes, we are contributing to, our tentacles reach far and wide here in Kentucky, all over the world. So risk factors for this disease are obviously travel to an infected area, travel to other places in the United States or other parts of the world shouldn't put people at risk for Ebola infection. It's that direct contact with blood or body fluids that we talked about that puts people at risk. Direct handling of bats or rodents or primates from disease endemic areas may put people at risk as well. And as we talked about, handling of a deceased person who's died of Ebola or who's been infected with Ebola and the preparation of funeral rites is also a risk factor for contracting this disease. So there's a lot of slides in here about the microbiology. I am not going to go through them, although to say that they're in your slide deck. I think the main thing that you need to understand is RNA virus, and that's probably about it from a clinical standpoint. Let's talk about the disease progression. We talked earlier about the incubation period. The disease course typically runs 2 to 3 weeks. As I said, initially this can present with some really vague symptoms that could be similar to other viruses, and that's why it's so hard maybe initially to figure out whether people have EVD or EVD. Fever and headache and malaise and gastrointestinal symptoms may be the first signs, and they may be the only signs. I think many of us think of Ebola as a hemorrhagic fever, and it is a hemorrhagic fever, but actually the minority of patients actually have that uncontrolled bleeding that we often see in the movies and in other concerns that we have about, when we think about hemorrhagic fevers. And there's a whole list of potential symptoms, and they also include rash as well. So this can mimic many different things, especially in the early stages. The problem is it usually progresses relatively quickly to more severe illness. And the severe illness can include coughing blood, bloody stool, bloody vomit, bleeding abnormalities, petechiae of the skin, and I think you can see that on this picture here. So in terms of the pathophysiology, endothelial cells, monocytes, and macrophages are all involved in this particular infection. The replication, unfortunately, overwhelms protein synthesis of the infected cells, takes over the host immune defenses, and then the virus evades the immune system by inhibiting early steps in white blood cell activation, and our white cells, of course, are what fights off infection. So it attacks that very mechanism that would help us to fight infection. And then the white cells also help, unfortunately, carry the virus to different places in the body. And then this causes us to release cytokines, which are what causes inflammation in the body, and that can then cause all these systemic problems that we normally associate with hemorrhagic fevers. Unfortunately, there is no specific treatment, and there are no vaccinations currently for Ebola. Symptomatic treatment or treatment of the patient's condition is the only real treatment at this point. So there's not any type of a magic pill. It's fluids, oxygen if they need it, and treating any complicating factors. And that's why the disease is so serious, because we just don't really have anything. There's some experimental treatments, one that's called ZMapp. It's actually made from part of the components are made from tobacco in Owensboro, I understand. It's really not been proven. It's too early to know if it's effective because we haven't done any randomized trials on it in the United States. as you've heard, some patients have received this experimental treatment. So how do we diagnose Ebola? First of all, let me say that the testing is not done everywhere. It's obviously done at the CDC, but at this point there are limited amounts of reagents. There have been 13 places across the U.S. that have been designated as Ebola testing centers at this point. Our state laboratory is not one of those places, so we do not have the capability here within Kentucky to do our own Ebola testing. I think the main testing that's being done is PCR or genetic types of testing. They can look at IgM and IgG antibodies later in the course, or they may want to look at that to see if somebody's been asymptomatically infected. I'm not aware that they're doing that, but that might be something that we will do in the future if we thought somebody was exposed, kind of like we did with MERS, but we weren't sure if they had an infection that might be asymptomatic. If we do have a potential case and we need to do some testing, our state lab knows how to send that to the appropriate laboratory. And there's a whole section of guidance about what type of serum to draw, what type of tube to put it in, and the precautions that the person who draws the blood needs to take, and how that needs to happen, and how we would get that into the appropriate laboratory. Obviously, if you get to that stage, we would want you to call us long before you're ever taking blood on a suspected patient. I'm hoping people understand that. So, all right, so let's talk a little bit about case definitions for Ebola virus. But a person who's under investigation has both consistent symptoms and risk factors. So this person would have fever, and they're classifying a fever as 101.5 or greater, and then, as we talked about, some probably type of headache or abdominal pain. Those are usually the first types of symptoms. And then, along with that, they would also have that risk factor, and that risk factor would probably be one of these things that we talked about. So it could be being taking care of Ebola patients in one of the affected countries. It could be being a family member of somebody with Ebola in one of the affected countries. It could be handling bats or primates or rodents who were infected in one of the affected countries. It could be a laboratory worker in one of the affected countries. But just traveling to the affected country without any of these other things as risk factors would not necessarily, that's actually considered to be, by CDC, to be no risk, okay? But, we'll talk about that later, they also want those people to monitor themselves for 21 days after they've left the country for signs and symptoms of Ebola. So, again, this is off CDC website, but person under investigation is contact of EBD case with either a high or low risk exposure, and we just talked about what high and low risk were, and confirmed case is somebody with laboratory evidence of Ebola. Again, we'll go over the high risk and low risk exposure. These are kind of a little bit out of order, but from the CDC standpoint, they consider somebody who was in one of those 4 countries, Guinea, Liberia, Sierra Leone, or Nigeria, that had a percutaneous needle stick with fluids from, contaminated from an EBD patient. They provided direct care. They were in some type of a aerosolizing procedure that had to do with a Ebola patient. They're a laboratory worker, or they participated in funeral rites, and they weren't wearing appropriate PPE, and they were kissing the body or handling this person and not washing their hands. Any of those things are high-risk exposures. Low-risk exposures are essentially providing care for somebody with EBD in the affected country, or you're a household member has Ebola virus. And then the no known exposures we talked about is that you just traveled to one of those countries in the last 21 I'm not going to go through this too much. Casual contact, that's on the CDC's website. Let's go to talk about prevention and control. So this is mainly for hospitals and healthcare facilities. We are developing some guidance here at the Kentucky Department for Public Health, but our guidance will be very similar to what CDC is now recommending. And essentially the Cliff Notes story about infection prevention and control in a hospital or healthcare setting is that these folks should be handled with standard contact and droplet precautions, okay? If hospitals and healthcare facilities want to go one step further and use precautions that would be more related to airborne diseases, they're certainly welcome to do that. They can always be more stringent, but CDC's minimum is the droplet contact precaution, standard precautions for these particular types of patients. If the patient is, they try to say you should try to avoid any aerosol generating procedure. Is that the right word? Anyway, a procedure that would aerosolize the virus. Try to avoid that in the hospital setting, but if you're doing that, then you will need to wear appropriate N95 masks, face shields, and that kind of thing. So that would be one extra level of protection if you're doing that with a suspected or confirmed patient. Again, please call us if you have any suspected or confirmed patients, and so that we can coordinate this with the healthcare facility and with your local health department.
Dr. Humboldt,
Yes.
just for an FYI, we also have invited the regional epidemiologist to participate in today's
Okay,
presentation.
great, excellent.
So there may be
Okay.
some, tips
Yeah.
that you may want to emphasize for them. I'm sure they'll be interested in receiving the guidance as well.
Okay, good. And these are just some, again, you can go to these websites if you have questions about what's recommended for healthcare facilities. There have been some travel notices and restrictions for these West African countries where the outbreak is occurring. You can also find those on the website, but essentially leisure travel has been curtailed, although folks are still going back and forth in terms of, folks like Doug or others that are providing, medical assistance or humanitarian assistance to these areas. So one of the questions is, what should you do when you're over there? Obviously try to avoid, but if you are working with personnel that have Ebola, wear the appropriate PPE. We're not aware that it's particularly infectious if the PPE is used. Again, practice careful hygiene, avoid contact with blood and body fluids, don't participate in funeral rites, don't eat bushmeat, and avoid hospitals where Ebola patients are being treated if that's not your job, and seek medical care immediately. So one of the questions has been about what happens with these patients, or not these patients, but these people who have been traveling and they were medical missionaries or they were participating in some type of care, and what happens when they come back to the United States. And we'll have some guidance on that. The current CDC recommendations is that they be monitored for a 21-day period after last exposure. So that would be after 21 days after returning to this country, and monitor twice a day for fever, a fever greater than 101.5, or for these other symptoms that we talked about. And if they have these other symptoms, they should immediately notify both their healthcare professional and their local health authority or a state health authority. Again, TJ has this, but we're drafting these cover letters that will provide additional information about precautions for healthcare providers when dealing with suspected or confirmed Ebola patients, voluntary quarantine of people who come back who've worked in these countries, and what we need to be doing from our public health standpoint in trying to identify anyone in the early stages if people do get sick, and then assessment and reporting of those individuals to the U.S. that are spending time in affected countries. One of our challenges is that obviously we don't necessarily know who's coming back from an affected country. We don't have that information. We don't have a list of people every day that are coming to Kentucky. So some of it will be based on self-report telling us that we have, you know, that they have been there and that they'll be monitoring themselves for 21 days period, and if they have problems, they'll give us a call. Again, I will reiterate, which I probably should have done at the very beginning of the talk, we've had no confirmed cases of Ebola here in Kentucky. We've had no identified cases. We have already had a few people that have been potential, so we've had to do some investigation on these folks because they've come here from other countries that are part of the affected outbreak, and they've needed to have investigation for one reason or another. I think, again, that's going to continue throughout Kentucky as long as the outbreak continues in West Africa. So we will have other people that may be flagged. They may have a fever when they come back. They may need to be worked up, or they may have other symptoms. And if so, we just need to be ready to know what to do at the local level to work those people up and assure that there's not a public risk from this particular infection. So I think that's pretty much the end of the slide. So thanks for bearing with me on a presentation that wasn't mine, but hopefully I got the points across. I think you also have this, I will show, this can be a color decision tree algorithm on when to test for Ebola and when not. Again, please call us if you're doing any suspected person, and we will walk you through this algorithm. But the long and the short of this algorithm is if they have high-risk exposure, then it's more likely that they'll probably get tested. If they have no exposure and they have no symptoms, then there isn't a reason for testing, but there is a reason to continue to monitor for that 21-day incubation period. So that's kind of the whole crux of this particular algorithm. All right, Joy, how do we get questions? Or do they just open up their lines?
Yes,
okay.
Yes. If anybody has any questions for Dr. Humbald, if you want to direct those to him, please. Or anybody here in the room?
I'm shocked there aren't any questions. I don't think I did that good of a job with the presentation. That wasn't mine. Well, everybody knows how to diagnose. They know what to do when they get that call from their doctor's office or from their hospital about somebody who's recently. I think those of you who have colleges and universities need to be cognizant that there could be returning students who are from these affected countries. They may be asymptomatic, but still will require some monitoring, self-monitoring on their parts for the 21-day period. As you all know, there are people every day that for business reasons go to other parts of the world. And then of course the whole area of if you have churches that may be doing medical missions, those are all reasons that you might have people that might be need to be monitored in your communities, or maybe even be at low or high risk for this particular disease. If you have any questions, please call us. Please call us on the front end rather than the back end. You know our number, right? It's 888-9-REPORT, and you can get a hold of us during the day or after hours using that number. Sue Thomas Cox, thank you for your question.
I have one question.
Oh, okay, go ahead. Who is that?
This is Amy at Bracken.
Yes.
Is this information about Ebola in the emergency communication guide that we have?
I don't know what the emergency communication guide is, Amy. I'm sorry.
Barb Fox.
Are you talking about communications for the public and
Yes.
for, I don't know that. That's a great question, and Barbara Fox had developed that a few years ago. So I need to ask our preparedness folks that if this is part of that communications guide. What I will say is, again, a lot of this, we may have to resurrect some of our plans from, for instance, colleges and universities may want to start looking at their plans that they had done for pandemic flu, because the isolation of these folks might be similar to what they were going to do for people who were isolated for a pandemic. And so they might want to dust off those kinds of things. Same with businesses if they're, have concerns. But it's a great question, and working with Joy, we will try to find out. Thank you.
Thank you.
Dr. Unlaw,
Yes, ma'am.
This is Jessica Austin. I have a couple of nurses, and they're
Okay.
wondering if we have had has DPH sent out any recommendations to the universities that they need to be monitoring this, or is this something we need to do on the local level, or they're getting guidance from somebody,
Yeah.
or?
Yeah. So guidance is going through clearance, but I'm part of the clearance, and actually I was up a lot of last night dealing with somebody who was a possibility here, who fortunately did not end up being anything that we need to be worried about, but that's why we're on call. And so I didn't get to all of the 5 documents that we plan on sending out, so I'm hoping to send those out by the end of the week. But it would probably be a good idea if you have a good relationship with your colleges or universities, just kind of contact them again and say, hey, this is in the works. We know that you probably have foreign students that are coming back from these places. Just this is the time to be aware, and also you might want to have some special oversight for these particular these particular students as they come back. Not excluding them from class or anything like that if they don't have any symptoms, but some way to make sure that they are self-monitoring themselves for fevers and signs and symptoms of the disease. So that's a great question, and I hope to have something out there soon. I haven't seen a lot on CDC's website about colleges and universities. I may have overlooked it, but that's why we wanted to send something out kind of along those lines. We've combined in our guidance businesses and business employees that may have been abroad with the same for essential guidance for college students who may have been abroad. And your other question, Jessica?
That was it. Thank you.
Okay, thank you. Sue?
That was part of my question, and it was the same thing with the businesses, or when you mentioned the churches, we do send out fairly often medical mission teams and try to get that information to the people who are going, and when they come back, but the monitoring is all self-monitoring. Is that correct?
That's correct. I think, for us here, we have essentially determined that it would be really hard for health departments to go out and monitor these people every day, but we do want to, I guess, emphasize that those folks should be calling local health departments if they have any signs or symptoms, within that 21-day period. So that's kind of the balance that we're walking, voluntarily. All right, well, any other questions? All right, if not, thank you very much. Appreciate it.
I do have one question.
Sure.
If you have 5 minutes, would you mind to give an update about the immunization registry?
Oh, sure.
Kind of what you shared with Kate on
Yeah,
Tuesday.
I'd be happy to do that. So again, we've had some questions, but I continue to direct them to if you have questions after, if you think of things after my kind of brief blurb, please call immunization program. And they're sitting here in the room with me, and I know that they don't mind and have had calls. So the immunization registry is currently on hiatus. We're working with the vendor to try to get some of the problems in that system resolved. I don't know what the date for getting it back and up and running is, but I do know that it's probably not going to be in the short term, and certainly not during this back to school season, which is unfortunate because I know that this is the time when people want to be able to print certificates from the registry. There are some workarounds for that, and they're all, I think, well outlined on the immunizations registry's website. They're also outlined if you actually go to the portal where you had access to the registry before. There's a page that tells you that the system is on hiatus and that these are possibilities for you to do workarounds. So one of the things that you can do, obviously, is the old-fashioned, and nobody wants to do this, but you know what we did 10 or 15 years ago when I was in practice is your assistant or nurse writes down every immunization on the certificate, and you can print a blank certificate from our website. So you can always go back to the old-fashioned paper method, although it may take a bit longer. Some other things, though, that you might do is, as a local health department, you can still print from the bridge system. I guess I would caution folks, just like any other system, no system is perfect, and so I would caution folks just to look at that certificate and make sure that it seems reasonable before you sign off on it, even if it's printed by the bridge. I think you should do that anytime that you get something from the electronic system. Just make sure that from the patient's chart and what you know that the dates are correct. And then the final thing is that we can tell providers, or even if you have an EHR, so if you have an electronic health record or electronic medical record, and I know that's probably more common in the provider community or in the hospital community, then they can configure their system so that it can print a certificate that would have all of the required information for school entry on the certificate, and that is also acceptable too as a valid certificate. So those are all possibilities. I think from our standpoint as public health folks, we need to educate our partners in education and also at child cares that they may in the last few years have been seeing a specific certificate that had the state seal on it that was printed out, but now with the immunization registry down, they may not be seeing that anymore, and there are these other valid options. So again, it's unfortunate. I prefer this not to happen, but we want to make sure the kids are up to date on their immunizations. That's the main thing, and that they're going back to school and they have a valid certificate within 2 weeks of school entry. So that's kind of my spiel on that. I wish I had better news, but I need to make sure that everybody understands where we are with that and that we are working with the vendor to try to resolve some of the issues that we're having with that particular system.
And where might local health departments go for those alternate options again?
Again, for alternate options, go to our immunization program, Kentucky Immunization Program web pages, specifically on school immunizations, and it's all those things are documented. Or you can call the immunization program directly if you have questions, and we have 3 very competent immunization nurses who are in here with me, and they will be happy to answer your questions or provider questions about back-to-school immunizations.
Any other questions for Dr. Humbach?
All right, thank you, Joy. Appreciate it.
I owe you lunch.
Yeah. No, you don't.
I owe 2 lunches today.
Have to see what the evaluations are.
There you go. There you go. Thank you, Dr. Humbach.
The 2 evaluations.
Okay. Dr. White, yeah, I've got it here. We'll leave it over here. Just a minute, folks. We're going to add Dr. White's presentation here.
Stand by. Operators are waiting for your call. Call 1-800-IMMUNIZATION. I was going to say call 1-800-HUMBA, but I like the 9 report. I thought that was pretty cool.
Next, we have on our agenda Dr. Connie Gail White, who is our Deputy Commissioner for Clinical Affairs. She is the second person I probably owe lunch to today. She volunteered late yesterday afternoon to come and speak to the local health department nurse leaders and public health nurse leaders regarding providing an update on the community health worker initiative. And I attended that initiative training, the convening on Monday at the Foundation for a Healthy Kentucky. And she and Sue had such a wonderful overview and status update of where we are as a state on this initiative. And we had some extra time, and so I asked Dr. White if she would mind to speak to the group today, and she graciously agreed to do that. So here's your presentation, and let me thank you very much. Do you want me to go ahead and switch you over to your presentation now, or do you want me to do that in just a minute?
Yeah, you can do, yeah, you go ahead and do it now.
Okay.
I don't think
I'm playing Joe Allen today, so.
I think everybody knows my face and doesn't need to see that anymore.
Okay. You can talk for long. You've got everybody else went. So if you want.
Oh, okay. So I'm
half an
between
hour,
them and lunch.
Yeah. Well, except for me. Except for me.
Oh, oh, that's right. You're
Yeah,
going to
about
talk
50
at the
minutes.
end.
Yeah.
Okay. All right. Well, I think I can cover, unless Sue has some things to add, and since nobody's seeing me except people in the room, I'm going to sit down. Yes, Joy came by yesterday and paid me a high compliment that, well, I'll just call Connie White because she can talk for an hour about anything. So I decided that was a compliment. I've learned that at home. Anytime my husband says anything, I just make it a compliment. So that's why I'm here. Joy has been very involved, as have several people been very involved in working with the community health worker group. And many of you out there are on this or you've called in. If you are interested in learning about community health workers in our task force, it is not a secret organization with a handshake and a Dakota ring. Anybody that is the least bit interested is welcome to participate. I didn't bring my notes from Monday, which I realize now I should have, because I actually went through the last email we sent out and got all the different kinds of people involved. So we've got people from the Office of Health Policy, we've got the Office of Health Equity, we've got chronic disease, we've got women's health, these are all state, women's health, chronic disease, me, maternal child health is there. And we also have people from universities. We've got Kentucky Home Place. We've got public health students and graduate school. I know I'm forgetting. Primary Care Association, the Kentucky Board of Nursing. We've got people that are with some nonprofit organizations, especially the folks that work with the refugee population in Louisville involved. So and it's grown. As people have said, well, what about? And I've said, well, I didn't think about them. Please invite them to feel welcome. The piece that we have been missing was the actual community health workers. And so, that's typical for not just state government, for any organization to come up with a great idea, and then they go to the people it's going to affect and say, look what we've done for you. What do you think about that? So we wanted to be sure that we got the community health worker involved as quickly as we could in the beginning of all this. This all started several months ago, and several things happened. One thing that happened was we had a graduate student from University of Kentucky who came to me. He was here doing a practicum, and he said, community health workers, have you thought about doing that? Because in my country, they've really made a great big difference, which I thought was kind of neat. And then at the same time, Dr. Mayfield was working with the ER superutilization program, and some of you are probably involved, and some of you are just now finding out about that. But it's an effort to take the patients that are overutilizing emergency rooms. We actually had 2 people in Kentucky that went to the emergency room in one calendar year 121 times. And they went to 32 different ERs, and 5 of them were out of state, and every trip was by ambulance. I agree with Commissioner Kistner, who was presenting yesterday in Hazard, when he said, I don't even know how anybody could do that. I mean, how do they helicopter from one city to the other to get the, I mean, that really takes a lot of work. And my comment is, I mean, do they have to stand up on a chair and say, somebody needs to help me because I obviously need help? If you're going to the ER every 3 days, you need some type of help. So the ER superutilization group was hospitals. They started with 16 hospitals that were connected to KHI, and we got the health departments involved. And after we explained to the CEOs at these hospitals what health departments are capable of doing, then they really saw these folks at health departments as the conveners, so that if someone is discharged or in an emergency room and they've been in the emergency room, and I think they've changed the definition. Before, a super utilizer was someone who'd been to the emergency room 10 times in the last 12 months. And they've modified that, and I don't have Dr. Leinfeld's slide, so please don't quote me on this, but it was a certain number of ER visits in the last 12 months plus so many admissions. So if you've been admitted, and I'm thinking it was 3, but don't quote me on that. So it's X number of ER visits plus so many admissions, that made you a super utilizer as well. Because there's a very small percentage of people using the emergency rooms that are using the biggest amount of services because of their frequency of going and their complexity of their medical conditions. And so that's when community health workers came in as these people don't need a neurosurgeon following them home and making sure they're doing what they're supposed to do after their stroke, and they don't need an APRN going home to make sure they're caring for their diabetes. They need somebody checking in with them, making sure they're following the orders that they've been given. Do they have questions? What are their barriers that they can't get the care that they need so they're not bouncing back to the ER? Also, the Affordable Care Act came out, very supportive of community health workers, and as of January 1, they can be called a part of the healthcare team. They can be recognized as part of the healthcare team. And to me, as a healthcare provider, when somebody's a part of the healthcare team, they should get paid for that, which is, I know that's an unusual concept for some people, but we in public health are now understanding better than ever that we have to be sustainable for us to provide services. So for folks that are out there listening that aren't the least bit interested in this, just listen anyway, because it'll be interesting information for you. And you may see that there is a role for this in your health department. And some of you out there I know are already actively working with folks that are doing community health care, community health worker types of services. And you may want to find out how can we make this a viable option for our health department and for our community. And it may be you don't have community health workers in your health department, but you might have community health workers in your community. So at least this will help you understand what they're doing and how you can be involved with them. So the talk that I gave, that Sue and I gave at this summit, and this was a summit to pull community health workers together, the Foundation for Healthy Kentucky sponsored along with us, and Kentucky Health One paid for lunch, so I always feel like we should say that. We appreciated lunch. To talk about CHW and the spa. So what I did was we put a sticker under a chair and I gave away a spa basket because I figured everybody thinks that, I know what I think of when I think of a spa. And so the next slide is just community health workers in the state plan amendment. That slide's much more interesting than this slide. But, and I like the way, and I'm saying some of the things that Sue Thomas Cox said because I didn't want to call her last night at 6 o'clock and say, hey, you're going to talk. So I figured since Joy gave me the authority to talk for an hour about anything, I could kind of paraphrase what Sue said. We have a state plan, a Medicaid state plan, and in that state plan, which I would advise you not to read because it will absolutely make your hair fall out. You can read it if you want to, but it is a humongous document that says everything we will do for Medicaid patients in our state, and that is approved by CMS. A state plan amendment is what it says. It's when we want to change that, this is what we need to do. So if we want to change our Medicaid contract with CMS, with the federal government, we have to amend it to say we want to include state community health workers as someone who can provide services in the state of Kentucky. And there is a certain way it has to be written. There's a certain way it has to be worded, and you have to figure out where you're going to attach it to what, and more things than I ever thought I ever wanted to know. So let's first talk about just a little bit of what a community health worker is. I usually don't use slides with this many words in it, and if you can't read it, I apologize, because I'm going to read it to you, because I hate it when somebody throws a slide up like that, and then they start talking about something else, and I'm trying to listen, and I'm trying to read. So a community health worker is a frontline public health worker who is a trusted member, incredibly important, trusted member of or has an unusually close understanding of the community served. This trusting relationship enables the CHW to serve as a liaison link and intermediary between health social services and the community to facilitate access to services and improve the quality and cultural competence of the delivery service. This is the American Public Health Association definition. You don't have to write it down, because if you Google APHA plus community health worker, this will come up. I'm not going to have Joyce send this PowerPoint out yet, because while I'm sitting back there watching Dr. Humbaugh, he's got the public health seal on his, and I don't have that on mine, and heaven forbid this gets sent out without that. For those who don't know me, I really am not a big fan of that symbol, and it doesn't match my color combination that I did my slides with, but I'll have to get over that. But I will attach that, and then Joy will send this out. But it's much easier if you just Google APHA and community health worker. It also goes on to say that a community health worker also builds individual and community capacity by increasing health knowledge, health literacy, and self-sufficiency. Actually, I think we wrote this. I don't think this is APHA, but this is still good. This is good stuff. Self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, health coaching, and advocacy. I like the health coaching. That's one of my favorite new phrases. So the thing that's most important is, if you read through this definition, this is not social work. This is not home health. This is not any of the things that already exist. This is what you might be doing in those roles. But what the new phrase is, and again, it's something I don't like, but I've gotten to learn to like it, called working to the top of your license. When I was a practicing OBGYN physician, I felt if a patient needed to go to the bathroom, I would get a bed can and I would stand there and let her do that. And the nurses would just throw an absolute fit, because they said, number one, it implied that I didn't think they did their job well. Nancy, is that right? Did we go rounds and rounds about that? Because I thought I'm standing there. I mean, I'm a woman, and women help. And I felt foolish walking out and saying, Nancy, Miss Johnson in 233 needs to go to the bathroom. Can you go in there and put a bedpan under her? I mean, I felt like a moron doing that. It just seemed like I was not being fair to Nancy. On the other hand, that would let me move on to the next patient, and Nancy could then look at the aide and say, go put a bedpan under the lady in 346. But my time should be used doing the things I'm best at doing and doing the things that are going to help the patients. So we're trying to get people to work at the top of their license. So if you've got a social worker making phone calls for transportation, that may not be the best use of her time. If you've got a community health worker doing that, that may be a better use of their time. If you're a home health nursing aide, then you should be changing a dressing and going on to the next house where the dressing needs to be changed. Not staying around helping somebody fill out some information or explaining the information because their literacy, not their health literacy, their literacy is low, and you explain to them why they need to fill this form out. There are so many things that we do as healthcare providers because we just feel like that's what we do. But because of our budget crisis and because of our ill patients that we have to be sure everybody is doing what they do best. So there is a whole gap there that community health workers can fill that have been proven in research all over the country that they get better outcomes, it is less expensive, and payers want to pay for this. Why would they not? So that's what a community health worker is. So it's not infringing on something somebody else is doing, but they navigate, they teach, you have to be careful about using the word counseling because they really aren't counselors. There are people licensed to do that. So you have to be sure that you're careful with your wording. But the health coaching and helping people set goals so that they will not need you there. Now, they may be somebody who will need you for always. And that's something that we'll have to figure out how we're going to do that, because some people just don't have the social support system that they will need help with their chronic illnesses. But we are hoping that there's a certain population that we can actually help be self-sufficient. So that's kind of what a community health worker is. So going forward, the Department for Public Health has convened these group of people. We are putting on paper words that we think will work for the Department for Medicaid Services. They're a sister organization in our cabinet. They're just across the road here, or across the hall in the mothership that I call the big space building where the rest of the cabinet is. And they will take our information and slice it and dice it and bibbity-bobbity-boo it and make it into what a state plan amendment is supposed to look like. So we need the Commissioner of Medicaid Services to be on board. We need to get people help us to write this properly. We're going to need somebody to write regs, because there are no regs that address what a community health worker is. So that has to be done. And instead of doing it in chronological order as usual, I'm trying to do all of those things at the same time. Because what we're going to say in the state plan amendment is that these people will be certified. Now, we don't have to say in there how that's going to happen, because we've got groups working on that right now. What will be the best way to certify these? Because if I'm the president of an MCO, I want to know that the person that we're paying for services, or the services provided, that these people have certain competencies that they've reached, and that they are someone who is worthy of being paid for their services. So there's an education group working, there's writing the state plan, and there's going to be regs going through or being written all at the same time. And then once the state plan amendment is blessed by the department across the way, then it gets shipped to Center for Medicaid and Medicare Services. I think I got that backwards. Medicare and Medicaid Services. Okay, I'll fix that before the official one goes out too. Once it goes to Washington, then we wait. And that usually is 3 to 4 months. Am I doing something wrong? Okay. We usually have to wait 3 to 4 months for an answer from CMS. What they'll probably do is they'll get it and they'll call and ask questions and ask for changes. And then they'll take that back and they'll call and ask questions for changes. So that's what that will happen. And so we're hopeful to get something by the end, by spring next year. That's my magic timeline. Because we're going to be sure that we put all the right wording in that matches the Affordable Care Act. The reason that this is also very important is, to our knowledge, lots of people are working on their SPA, but nobody has actually submitted a SPA to CMS for community health workers. It's been recommended since the ACA has come out. People are using community health workers in Minnesota. They're paying for it out of state general funds. Lots of states are using them out of grant fundings. Jan Chamness has a program that she's had for quite some time through some HRSA funding. Dr. Fran Feltner has been training home place community health workers for quite some time. That's supported by state general funds. So they're out there, they're doing things. In fact, there is a definition of community health worker the Department of Labor has, and in Kentucky, 400 people are called community health workers by the Department of Labor. We don't know what those folks are doing. They may be doing very many different things. In order to have community health workers that are billable, you have to be a Medicaid provider. So that's important for those groups that are doing nonprofit work, because since they're not Medicaid providers, they cannot hire and bill for a community health worker, but they could certainly have an engagement with a local hospital, because emergency rooms, I know, have community health workers. If local health departments want to get involved in that, organizations can then, if they have a Medicaid billing number, use a community health worker. It will be billed under the provider's name, but the community health worker will be doing services. So that's kind of the very boring things that we have to talk to people about. But I think it's important that you understand it's not like when I was in practice and I got up in the morning and said I want to use a community health worker and I hire somebody that afternoon and they start next Tuesday. It doesn't work that way. So there's hashing out what we want to ask for, asking DMS for it. DMS writes the state plan. We submit it to CMS, and CMS finally comes back and says, yes, you can do this. So that's where we are on this. You're going to hear more and more about this as time goes on. Hopefully, a lot of you will see that there's a niche that you can do this in your community. And I think y'all know how to find me, connie.white@ky.gov. Sue, did I leave anything out that you can think of? Obviously, I'm passionate about this, but I don't usually do things I'm not passionate about, and I'm passionate about lots of different things. I got introduced yesterday, and the secretary was going through all the things I was involved with, and I wanted to get up and say, I just obviously can't focus, can I? It sounds like somebody with ADD. Oh, look, there's a chicken. But this is one that I'm very excited about, and I really think it's going to move Kentucky forward, because all of us want to do these things that community health workers are doing. You know, I stay at my office till 9 and 10 o'clock almost every night trying to do these things for patients, because they just can't do these things for themselves. And it's not reasonable for the physician or for the nurse to be able to have the time to do this. It would be great if they want to. And if they want to get an extra room in their mansion, they can do this. But we need to find a way that this is sustainable. This will be a job for someone. This is going to be somebody that will be either a high school graduate or a GED person. And there are folks out there that love to give, and we need to give them that opportunity. We need to give the help to our patients who are floundering. I mean, I've had conversations with people in this room. How do we get back to? I think everybody's got that part. People in this room that I've had conversations with who have said, you know, my mother-in-law was sick or my sister was sick, and I had a heck of a time getting everything to happen. You know, so if we're having those troubles, imagine patients who aren't literate or are barely literate, who are in a situation where they don't even feel like they have the right to ask for help. That's part of what community health workers do. They do motivational interviewing. They coach people that, yes, you have a right to ask questions. Help them through that white coat syndrome. Help work with their families, because if you've got a sick patient and they don't have family support, if everybody in the house is eating what they want to and this poor diabetic is struggling and there's 3 liters of Mountain Dew in the refrigerator, I mean, it makes it hard. Can we find ways to help the family as well as the patient? And I'll do a shout out to Holly West. There is also a program called Healthy Homes, which I think y'all have talked about, and there is a Healthy Homes track for community health workers. So this is another service that they can offer. So I think the boundaries are endless. We won't tell CMS that, but I think the boundaries are endless of ways that community health workers can really help. We have a bucket load of chronic disease in this state, and this is, I think, a piece that's missing. You know, it doesn't matter how good of a physician I happen to be, I can only treat diabetes till you walk out my door. And then what else can I do then once you leave the parking lot to help you? And I think this is where our next step is going to be. So I did my 15 minutes. Questions from anybody? We'll start in the room, because if somebody in the room has a question, that makes everybody else have questions.
What about the time frame, Dr. White? Can I ask you about that? We discussed that briefly at Monday's meeting. Time frame, we are going to take the thoughts from the community health workers that we got on Monday and make sure that we've got all that captured on paper. And there was a public health graduate student that is interning at Foundation for Healthy Kentucky who was taking notes like crazy. So he's going to synthesize the day. We're going to take that. We're going to take that to somebody in Medicaid who has been our CHW friend, who's helping us say, oh, no, you can't use that word, because in Medicaid world that means one thing, and you really, in public health world it might mean this, but in Medicaid world it means that, and that will raise a red flag. Well, you know, we don't want any red flags. We want the American flag. So we'll change whatever word she tells us to change to make it fit what their thought processes are. I mean, the first month I was here, and Joy asked me if I wanted to come to the NEC meeting, and I said, really? And she said, yeah. I said, how often do they meet? And she said, I think it was every other month. I said, there's that much of a problem with necrotizing enterocolitis in Kentucky that you've got a group that meets every other month? And she said, no, that's the Nursing Executive Council. So different words mean different things to different people. So whatever words Medicaid wants us to use to get our point across in their lingo, we will do that. So I'm hoping we can get that done
in Connie time would be November, December. I'd like to do November so we can get it to CMS in December. And so it will sit on somebody's desk until January when they come back from holiday and they can start working on it in January. I don't know these people at CMS. I'm sure they've got a lot to do. But that's why I'm hoping 4 months, that maybe April, May, we will have some type of answer to give us time to take, because they're going to edit it. It's like an IRS review. They're going to find something wrong with your taxes. So whatever they want us to change, we'll work really hard to get it changed quickly. That's my timeline in my mind. I haven't met anybody who said that I was delusional yet, but so I'm going with that timeline, and then we'll see if we can't get that done, because the services are needed. We can't just have another unfunded mandate and hire these people, because people are our biggest expense and they're a big part of our budget. We have to be able to replenish that budget. So we have to be, this will not just be for local health departments. This will be so if Baptist wants to hire them in their ER, or Kentucky One Health, if FQHC does, although they get paid by the batch, they don't get paid by the service, so I don't know that for FQHCs, but I think it would be good if they had recognized community health workers that have gone through whatever competencies that we work out here at the state. I could have used this community health worker in my office. I would maybe still be practicing if I had not burnt myself out doing that. And I've never said that publicly, but I just did. I'm on TV. I'm on the internet. Are we on the internet? No, probably not. It must be true if we're on the internet. So questions? Anybody have any other questions out there in cyberspace? I'm like Dr. Humble. I wasn't that good. So.
Would you mind just to touch on the board or the association that will be a component of this project?
Yes, thank you. The question was about an association or an alliance. At this meeting, we had 2 women from Indiana. They are community health workers. One, it was interesting, one is very clinical. The other one is a pastoral type background that works with refugees in the refugee population, but they both were very integral in getting, it was INCHW, Indiana Community Health Worker Alliance. And so these were, the community health workers actually got together at the beginning and said, we want to be recognized, we want to be valued, we want somebody to understand what services we provide. And they have been trying to get the Indiana Department for Public Health's attention to help them with this. We're kind of going at it a little bit differently. We recognize this service, and now we are supporting and being as hopeful as we can that from the meeting we had Monday, we had one of our World Cafe breakout groups was on how to form an alliance. So we've got a listserv now, we've got email addresses, we're going to send some information out, and we're hoping that these folks will see the need to bind together. It was interesting as we were going around the room introducing ourselves, one woman said, I'm Connie White, and I'm from White County, and I'm a community health worker, and sitting next to her was, oh, well, my name's Joy, and I'm from Hoskins County, and I'm a community health worker, and our counties were next to each other. So I'm in this county doing community health work, and she's in this county next door doing community health work, and they didn't know it. So that's an instant, a resource right there. Obviously, what they do in Jefferson County is going to be different from what they do in Laurel County. But there's still some common information that people can share. So we're hopeful that with some encouragement, and the biggest thing the people in Indiana says, we just need some administrative staff, to send out emails, to send out articles, to call meetings, or not to call the meeting, but to do the legwork. And you guys know, if ideas die if you don't have a clerical person that keeps it moving, and that's what we think that we can help offer that to help them. And the foundation was very interested in being helpful with that. So there's a lot of excitement about this. Any other questions? I'll keep you updated. More to come as things happen, so we'll let you know. Thanks for having me today. Appreciate it.
Here, let me give you your thumb drive.
Oh my gosh, yes. unction about that baby.
There you go. Thank you. Alrighty, we're going to go ahead and wrap it up. I do have several announcements for everyone today. Want to share with you. I've got 5 different bullets. So let's see, 6 bullets. That'll help keep me on track. The first is a reminder about the APRN conference. This is I believe, our 6th year to host, for the nursing office to host the APRN conference, which will be held September 23rd and 24th in Bardstown at my old Kentucky home. Dr. Farr, who is from University of Tennessee, he will be providing the 5-hour pharmacology CEs on that Tuesday, the 23rd. He has confirmed for that day. The APRNs, and I've CC'd the nurse leaders and the directors, but the APRNs have received the information for save the date and their hotel information. We're finalizing the agenda now, and as soon as all that information is compiled and submitted to Bob Allen for CEs, we'll go ahead and get that loaded on train for registration. Remind your APRNs and your directors that there's no conference registration cost. Meals are provided. The only cost that would be incurred for your APRN to attend this meeting, this training, is travel and overnight accommodations. So we hope that our APRNs, the public health APRNs, will be able to participate, and more information will be forthcoming as the agenda is finalized. And that will be coming from me if you're watching for those emails. Next, I wanted to read an update about the APRN collaborative agreement for non-scheduled medications. As you all know, this legislation that eliminated the need for a collaborative agreement or a CAPA-NS for APRNs after 4 years. That went into effect on July 16th. And so I'll read to you the posting that was on the Kentucky Board of Nursing website. All APRNs were to be notified on July 16th by email or via U.S. mail with the details of how to request to discontinue a collaborative agreement for prescribing authority for non-scheduled drugs, the CAPA-NS, after having a CAPA-NS in place for 4 years. You must complete a notification to discontinue the CAPA-NS after 4 years form. So there's specifically a form that your APRN will need to complete and submit to KBN if she has 4 years of practice with an experience having that CAPA-NS in place. For those APRNs who wish to continue their CAPA-NS, you must complete a notification of a collaborative agreement for the APRN's prescriptive authority for non-scheduled legend drugs, the CAPA-NS form. And so if your APRN will go to the KBN website, there's hyperlinks for each of those forms, and they will want to click on the appropriate form, whether they have more than 4 years or less than 4 years, and those notifications must be submitted to the Kentucky Board of Nursing. So and they must be submitted to KBN via email, fax, or mail as noted. If for a particular reason APRNs can continue to maintain a CAPA-NS after 4 years of experience, they can do that voluntarily. But they're not required to. So there's not any additional guidance or restrictions or anything like that that DPH will have. We'll be following the law and the regulations as written. I am working on updating the administrative reference. You may know that the sample collaborative agreement is in the personnel section of the AR. So I need to work on updating that information to reflect the guidance that's currently on the KBN website. What you'll also find, there is a whole list of frequently asked questions regarding Senate Bill 7, which is the legislation that changed the requirement for the Kappa-NS. So you may want to suggest to your APRNs, or you as the nurse leader might want to go out to the KBN website and review the frequently asked questions. So wanted to let you all know that was in place. Your APRN should have received that email directly from the Kentucky Board of Nursing, and they would have been instructed to submit that documentation as required. Are there any questions specifically about the new law, the new requirements about the Kappa-NS for APRNs?
I have a question.
Sure.
If our APRN has the 4 years of experience, but as an agency we are requiring that she keep the collaborative agreement, does she have to do anything on the KBN website?
No. No, the Kentucky Board of Nursing issued guidance regarding that, and I'll be glad to send that out. You're saying that your agency requires a collaborative agreement after 4 years?
Yes.
Okay. I'll send that guidance to you. The Kentucky Board of Nursing has issued guidance that requirement is not consistent with the law as written. So I'll be sure to send that out to you. Can I have your name?
Yeah, this is Karen Fallon.
Okay, Karen. Okay.
In Justin County.
Sure, Karen. I'll be glad to send that to you. In fact, I guess I could just send that out to everybody. That might be helpful. Oh, and I can include that also in the AR. Would that be? Yes.
Do they have to be with the same agency for 4 years, or if she practiced with another agency and came to us, is that sufficient?
Yeah, it's 4 years total. And on the form that she submits that documents or attests that she has her 4 years of experience, I believe there's lines that say that, you know, she had a collaborative agreement with Dr. Smith for 2 years, and then she had a collaborative agreement with XYZ local health department for 2 years, and so she has her 4 years in.
Thank you.
And there is an attestation statement as a part of that document that needs to be submitted to KBN for after 4 years of experience. Other questions? Okay. And if you have any, and I have received a couple, if you have any questions, just let me know, and I'll be glad to assist or refer you to the Kentucky Board of Nursing website. Okay. The next point I'd like to share with you is just to update you on the Nurse Executive Committee meeting. Our first meeting of fiscal year 15 will be held next Tuesday, and I'd like to share our members with you. Shelley Adams from DPH, Tammy Bertram from Franklin County, Joanne Campbell from Powell County, Alicia Combs from Montgomery County, Maria Dalby from DPH, Lois Davis from Fayette County, Marcy Fleckler from Bullitt, Nancy Hamilton from DPH, Amy Maines from Bracken, Vicki Morgan from Buffalo Trace, and LaVon White from Louisville Metro. So each of those nurse leaders have been invited to rejoin us again for fiscal year 15. They were on our FY14 NEC committee. On Tuesday's meeting, we will be reviewing the charter for our organization, our committee that we worked on last meeting, and so we're going to review those changes. And then our first assignment that we've given ourselves is to work on the development of core competencies for public health trainings for the public health nurse. So you may have noticed that the training guidelines in the administrative reference have a blank line there for that acknowledges that the core competencies are under development. So we're going to work on those this year, and that will be a fairly big undertaking, but we've given ourselves that homework assignment. We want to get that part completed. I had the immunization protocols listed, but we've covered that with Jan, so thank you very much, Jan, for that information. Then next, I wanted to share with you all at the June 19th Public Health Nursing ITV, you may recall if you were able to participate with us, that when Tracy Vaughn was presenting on Shiga toxin and the NEDS documentation segment, the CDC website was down, and so she wasn't able to present the NEDS information. She graciously came back and retaped that segment, Tracy did, with the assistance of Education and Workforce Development Branch. So that archived version of the June 19th PHN ITV is now available, and what they did was they spliced Tracy's retaping of the NEDS information and plopped that into the rest of the ITV. And so if you missed that ITV, you will now be able to review the complete training, and the train number is 1052471. So that's the archived version of the June 19th PHN ITV with the complete information. If you are a nurse or an epidemiologist, for example, who just wants to review the Shiga toxin and the NEDS demonstration, that was also taped and given a train number as a standalone training, and that train number is 1052482. And that was given a 1 CE as a standalone presentation. So if you have folks who need an initial training or an update training on NEDS or Shiga toxin or both, that is available. And I'll send that out to everybody. I just had promised you all that we would work on getting Tracy's presentation up and retaped for you all, so that is available, and I wanted to let you know. And then lastly, I wanted to share, I sent out this morning a training opportunity for integrative nurse coaching. Carla Bowman, who is our friend and retired nurse leader for the Madison County Health Department. She is the instructor. The CE will be provided at a farm in Paint Lick, Kentucky on either September 11th or November 13th. And the training times are from 8:30 to 5. So I sent that information, the flyers and the registration information and Carla's contact information. I sent that out to everybody this morning before this morning's ITV. So please feel free to review that information and register and attend if that's of interest to you all. Okay, I think that covered my bullets. Are there any questions or comments or concerns or any other topics that we can discuss today? I thank you all for your patience and letting us kind of juggle the presentations and the presenters, and I know that that's difficult to get everybody there at the right time for specific content. So thanks again for your patience. The next PHN ITV will be October 16th. I think I wrote that down. Yeah, October 16th. So please mark your calendar, and we hope you can join us then. Thanks, and have a great day.